And many other clinicians, many colleagues, as they present their materials, you're going to hear the same common theme over and over. And that just kind of shows you the validity and how important it is to understand treatment planning, how it really has to be prosthetically driven. And today in 2025, anything and everything we do with implant dentistry really revolves around proper planning, diagnosis, treatment planning, and then understanding the final prosthesis. And so my presentation this afternoon is going to discuss immediate implant placement, which you've heard from several of our wonderful colleagues this morning and this afternoon. Pointer? So we're going to really focus on the anterior aesthetic zone. And so today's presentation is really going to focus on the aesthetic smile, especially when we're dealing with single tooth implants in the aesthetic zone. And as I mentioned this morning, one of the hardest, if not the hardest, treatment plan to execute is going to be that single anterior implant case. And so I would ask you, what if you lost one of your central incisors? Right? Many of you are very young here. Think about how many years you're going to have that implant in your mouth. 10 years, 20 years, 30 years, maybe 40 years, right? What if you lost your front tooth? What would you want replaced? How would you want it replaced? Right? How would you want to restore your case? Who would you ask? Take a look at your friend, your neighbor sitting next to you, and ask, do I trust him to do my implant in my mouth? Take a look. Huh? So you want to think about that, because anything and everything we do for our patients, you want it to be functional, you want it to be biologically stable, you want it to be aesthetic, and you want it to last. You want it to be beautiful. And so beauty lies in the eyes of the beholder. Again, take a look at your neighbor, right? Do you think beauty is similar to what you think of beauty? What do they consider to be beauty? And so we can do a little comparison, right? This gentleman on the left here, or her, everybody knows who she is, right? Right? Jennifer Aniston. Nice, beautiful smile. Nobody really knows who this gentleman is, right? But if you look at him, do you want to look like him, or do you want to look like her? I think I want to look like her, right? She's got the more beautiful smile. And so beauty really lies in the eyes of beholders. But if you look at him, he looks pretty happy. And many people, they look pretty happy, even though if they're missing one tooth. Remember the case I showed you this morning, that gentleman with the front anterior implant? He was happy with his single implant. So aesthetics really depends on your personality and what you think is beauty. And so whoever you choose is really dependent on what you prefer. But think about what your patients are going to want. And so we want to understand that restoring the single tooth, maxillary anterior central incisor, or any anterior tooth is probably going to be the most difficult procedure in implant dentistry. And so I will warn you, don't choose a central incisor as your very first implant case, because it's hard, it's difficult, right? And so it can be the most challenging case you do. That case may change your mind about doing implant dentistry. Maybe you don't want to do implant dentistry after that first case. But we want to make sure that you can still accomplish a successful result if you follow certain guidelines, certain protocols, okay? When we look at the history, we know implant dentistry works. It started off following traditional Brandenburg protocols. Usually when they did implants back then, you place your implants, then you have to wait 6 to 12 months to let it heal, right? You have to make sure that it's buried, there's no forces, but understanding the whole procedure can take 1 year, 1.5 years. That's how the original protocol was performed. You know, but today in 2025, most people, most patients, and even clinicians, they want it done faster, right? How many of your patients came to your office and asked you, how long is it going to take? When am I going to be finished? They all ask that same question. And so today, they're asking for faster treatment, right? So patients want it, clinicians want it, and sometimes even companies promote it that we can do faster treatment. But can we, as a clinician, can we, as a provider, provide that faster treatment? Sometimes yes, sometimes no. And so we want to make sure that we can be productive, we can be predictable, and that we can be simple, as we heard, right? Simplicity, but making sure that it can be reproducible. And so when we look at immediate implant placement, it's very hard. Immediate implant placement is very different from delayed implant placement. There's a lot more planning, a lot more thinking that we have to know. But understanding there's advantages, right? Because when we do immediate implant placement, the total treatment time can be reduced, right? It doesn't take 1 year. It doesn't take 1.5 years. There's less patient visits. Patients, they don't like going to the dentist, right? We know that. So they don't have to spend as many visits going to the dentist. There's a higher patient acceptance. More patients will say yes to doing implants. If you say, well, I can finish this probably in about 6 months, or would you want to spend 9 to 12 months? Most of them will say 6 months, right? So less patient visits, higher patient acceptance. When we do immediate implant surgery, there's less surgery involved because we're combining multiple procedures. So we reduce the number of surgeries. And hence, we can preserve alveolar bone, we can preserve the tissues, and ultimately, that's going to help us maintain a little bit more predictability. What's one of the disadvantages of doing immediate implant placement? What would you say? Obviously, the answer is going to be failures. There's unpredictable gingival recession. When you do immediate implant placement, we don't know exactly where the soft tissue is going to wind up, right? So it's unpredictable. We can anticipate maybe some crustal bone resorption, because when we do immediate implant placement, we're arbitrarily placing an implant where we think it needs to be. And if it's not in the proper position within the bone, then sometimes we can induce bone loss. Okay, so these are some of the disadvantages. I'm going to do a little test, a little question. So if you look at this patient here, there's a couple of implants. So which one do you think is the implant? So I will say, how about this is 1, 2, correct? Number 12, is that the implant? How many says that's the implant? How about this one? 1, 1? Anyone say 1, 1? Okay, maybe a few hands here. How about this one? Who says that's the implant? Anybody? No? How about this one? Is that the implant? Maybe. Okay, maybe the lower teeth. Anyone say the lower teeth? So you don't know. You don't know which one's the implant yet, right? So what if I do this now? Have the patient smile a little bit. Now which is the implant? Who says 21? Is that right? No, 12. Who says 12 is the implant? Who says 11? 1, 1. Okay, who says 1, 2 is the implant? Maybe. How about this one? The lateral incisor. A few more hands. How about the lower incisor? Anyone say lower incisor? No? Okay. So some people say here, some people say the central incisor number 21, someone says 22. Which is the implant now? Oh. Huh? Look at which is the implant. That's pretty obvious, right? So this is my implant patient case. My implant patient case. That's an implant. Right? So this is an implant and aesthetic failure. We have a problem. I didn't show you the complete picture though. So this is only the clinical picture, right? If I show you the radiograph, oh, we have two implants. Two implants, but two completely different clinical results. What happened? Why do I have two implants with two completely different clinical results when you look at this picture? Right? Did you know that this was an implant? Maybe. Did you know this one? This one's pretty obvious. Right? So this is a very difficult case. This was my patient, my case. I did the implants, I did the crowns. And so this was a very challenging case. So those two were the implants. Okay? So now we have to figure out what happened, why this happened. And so if I walk you through this case, you know, ultimately when I did this, I said, you know, how do I resolve this problem? How do I fix this problem to make sure, I'm sorry, how do I understand that I want to prevent this from happening for my next patient? So this case was a case where a young female, 40 years old, maybe not so young to you, right? But to me, she's young, okay? So 40-year-old female, she had an accident. She fell and she hit her mouth on the concrete floor. And so she actually was out celebrating with her colleagues at work because she got a promotion. And so she wanted to go celebrate. And so she wanted to have a nice dinner because she got the promotion. She went out to dinner, had a few drinks. Then after dinner, they wanted to go celebrate more. So they went to a local bar. They had a few more drinks. And by the time around 11, 12 o'clock came, you know, the alcohol finally caught up to her. And when she went out, she tripped on something and her face hit the concrete floor. So this was a Friday night. She calls my office, she calls my cell at emergency saying that she has an emergency. I didn't know it was an emergency. And so she was already waiting at my office Saturday morning. And so when she came, this is how she presented. So these black marks are marks from the concrete when she fell. So severe trauma, severe accident, she fractured that incisor coronal third. And so she comes to our office asking for help. And this is what the radiograph looked like. Right? The tooth practically out of the socket, fractured third. So how are you going to plan this case? What are you going to do for this patient? Any suggestions? Refer to your surgeon, refer to your prosthetist, right? But you're the dentist and you need to take care of her. What if this was your friend sitting next to you? What if he came and asked you, can you help me? How are we going to restore this case? So we have options. When she presented to our office, the hot topic in dentistry at the time was immediate implant placement. And so everyone that was involved with implant dentistry at the time, they wanted to immediate implants because they knew that it was going to work, or they heard and thought it was going to work. You know, what better solution is there if you're going to lose your tooth? Take the tooth out and put an implant in right away, right? Solve all problems. And we knowing at the time the success rates of immediate implants, thinking that it was going to work, we felt that was the best long-term solution. And so our plan at the time was going to be do endodontic therapy on tooth number 9. We wanted to save that tooth. We'll build it up with some composite temporarily. We'll go ahead, we'll extract the lateral incisor. We'll remove the tooth. we're going to place an implant immediately, and we're going to provisionalize at the same time. So that was the proposed treatment plan. And since this was a Saturday morning, so Saturdays in my office back at home in New York, it's pretty busy because a lot of patients want to come Saturdays when they're not working. And so I'm trying to spend time keeping with the schedule and then treating her in between patients. So she was in our office on that Saturday for about 6 hours, just doing the endodontic treatment, removing the tooth, placing the implant, trying to make it temporary, just trying to do everything in one visit to try and help her so that she can be able to go back to work Monday morning. You know, she was pretty scared. She was nervous, right? She was upset, but you know, she just received a promotion, so she has to be back at work Monday morning. So we're trying to find a solution to help her. And so that's what we're trying to do. So our plan at the time, because immediate implant placement, that was the hot topic. We said, you know what? Look at this tooth here. It's practically out of the socket, so we could take that tooth out and I'll put an implant in right away. Makes sense, right? And we thought that was going to be the best solution. So that's what we did. We went ahead, we took out the tooth. I showed you this picture this morning. Look at the position and placement of the implant, right? So remember that. Look at where that implant is. We said a little bit too buckled, okay? So that was the immediate implant placement. We go ahead, we're gonna fabricate a provisional. Remember this morning with the fixture mount, we prepared that fixture mount and we used that as a temporary abutment. And then we went ahead and we also grafted. So the buccal plate had a little bit of fracture because of the trauma from the accident. And so we saw that, and so we said, you know, because of the deficiency in the bone, we're gonna graft that buccal plate. So that's what we did. And then we're gonna go ahead and we're gonna fabricate a provisional. So here's the before, and there's the after. So that's the same day with the radiograph. It's not too bad, right? Not too bad. So here's the tooth that was treated endodontically. We have some composite buildup. We'll do a future crown when it heals. And then there's the immediate implant in site number 10 or 22 with the temporary abutment. How did I provisionalize? Can you tell? How did I make a provisional? That's her tooth. I used her tooth that I extracted, I cut the root off, and I used that to reline over the temporary abutment. So we used her tooth to act as a provisional. So that's the best temporary that the patient can walk out with, her own tooth. She can't really say, oh, I don't like it because it's not aesthetic, because it's her own tooth, right? So, and because it was the same day, emergency treatment, we felt we can temporize her using that tooth. So this is 1 week post-op. 1 week post-op, actually, it looks pretty good, right? It looks not too bad, healing. And I'm feeling good, I'm happy because, wow, we were able to provide a great service for this patient. From the trauma, she came in, we were able to take the tooth out, put an implant in, we did a little bit of bone graft, and we gave her a provisional, and look at how it's healing. That looks pretty good. So 2 months later, she comes back, and still, not too bad. Huh? Not too bad. A little bit of staining, but look at the provisional. You know, we talked a little bit about the provisional. You want to use your temporary to help stabilize the soft tissue, right? So that's what we were trying to do. So tooth number 9 actually started to fail, right? The central incisor, sorry. The central incisor started to fail. She kept complaining about pain, discomfort, you know, sensitivity, and, you know, at the time when she came, we said, you know, what do you think we're going to suggest? Immediate implant placement. If you're symptomatic, it's bothering you, long term is probably not very hopeful, the prognosis is poor, so let's go ahead and we'll extract that tooth and we'll do the same procedure. And that's what we did here. So we performed the exact same procedure that I did with number 10. We take the tooth out, we'll place an implant, we're going to provisionalize, and we're going to use her tooth again to give her a temporary. So that's how we stabilized her. A few months later, now we're getting ready for the final prosthetics. And so another hot topic at the time was to use zirconia abutments, because that's going to give you the best aesthetic result, because we're talking about aesthetics now. So at the time, a lot of clinicians were talking about zirconia ceramic abutments. And so we said, okay, we're almost there. And now we can go ahead and we can complete our case. And yeah, it's not perfect. It's not perfect, but it's okay, it's decent. Patient was happy. We felt pretty good because we got 2 single implants. We have zirconia abutments, right? We have all ceramic crowns. And so we're feeling good because we have the best of all the best. We're trying to make this case, you know, marriage art and science, right? We're using our artistic skills, using all ceramic crowns, all ceramic abutments. We're trying to use biology and science to make sure that we have the best of the best in terms of implant placement, right? So we're using all tools in our belt so that we can hopefully maximize the results. And it wasn't until we thought that case was complete until she came back for recalls, right? So we talked about maintenance. And so I'm treating my patients. This is about 3 months after we finished the case. Patient comes in for her regular checkup and cleaning. Hygienist comes and says, Dr. Kim, you know, so-and-so, let's say her name is Jenny. Jenny's here for a checkup. I'm busy, I'm doing her case, and say, well, how's she looking? I say, okay, how's she feel? She feels fine. And so it's okay, then you know what? Reappoint her for another appointment. Put her 3 months later, I'll do the checkup then. No, Dr. Kim, maybe you should come take a look. Oh, I'm busy, I'm doing another procedure. I don't want to be bothered, right? I don't have time. I say, no, Dr. Kim, you should come really take a look. Fine, okay, I go. And I go and take a look and say, hey, Jenny, how you doing? How's everything feeling? It's okay, everything looks good, it feels fine. Except when I pull my lip up, Dr. Kim, there's something dark there. And so I sit down, I do the exam, you know, I check everything. I see this black margin, and I'm speechless, right? Because I know what that is. You know what that is, right? That's the implant, because the white, that's the ceramic, the zirconia abutment I was using. The dark metal, that's the implant that's showing through. And so I sit there and I'm like, I didn't know what to say, because I know this is not looking good. She pulls her lip up and it's like there's a dark area. What do all patients do when you finish anterior crowns? They smile, you don't see any margins, but what do? They lift up their lips. Oh, what about this? What about my gums here? That's what Jenny did. And do you know that feeling when you get nervous and that cold chill goes down your back, right? Oh, because you don't know what to do, you don't know what to say. That's the feeling that I was feeling with her. So I asked her, Jenny, what type of toothbrush do you have? Are you brushing too hard? I said, no, I don't think so, because I'm trying to find an excuse. Are you brushing your gums too hard? Make sure you use a soft toothbrush. Extra soft. If you don't have one, I'll give you one. Okay? Because I'm trying to figure out what happened. And so I say, okay, come back in 2 weeks, we'll do another checkup to see how the gums look then. Because I didn't know what to say to her, and I didn't have an answer. So she comes back, this is my case. I need to do something, right, to be able to kind of correct what's going on. And so we try to come up with a new treatment plan. We thought about grafting, which we did one time. We thought about maybe having to redo the whole case, which when she came back, we realized that that's what we have to do. We have to redo the whole case. Take out that failed implant, right? Because we had so much recession, bone loss, right? Gingival recession. So we took the implant out, we grafted, and then we tried to regenerate that area. And so this is a provisional, this is a titanium reinforced membrane that we're using to try and see if we can stabilize the graft. to try and regenerate that area. And so this was becoming a problem because we're doing multiple surgeries now. Right? We don't know if we're going to get regeneration of the bone. Right? We don't know how much bone we're going to be able to regenerate. And so we have to understand, now look what's happening. It's getting worse. So I'm doing bone graft thinking that I'm going to try and improve the situation. But in reality, I'm actually making it worse. I'm getting more bone loss. I'm getting more tissue loss. So now it's becoming a bigger problem. Now what do? We have to understand and know our limits. We have to know our limitations. Things are going bad and it's getting worse. Am I going to send this patient to now maybe another colleague, an oral surgeon, or another periodontist? I really couldn't, or I didn't at the time because it was embarrassing to me because I'm causing all this trauma, I'm causing all this bone loss, I'm causing all this failure. And so it really was an eye-opening experience because we went ahead and we went and placed another implant after grafting. We placed, in this case, a smaller diameter implant, and then we had a final prosthesis made. So that's the final result that we finished this case with. And so you see the difference of what happened here, right? And so understanding, this is what she looked like. She didn't really smile because she was compensating her smile, right? It wasn't a full smile because many patients, when they're conscious about aesthetics, they're really subconsciously, they'll mask and minimize their full potential smile. And so this is how we started this case with this patient. That's the direction we thought we were going, thinking that we're coming to a good result. And then thinking that we're almost there, home free, with ceramics, with biology, right, with implants, but ultimately leading to this failure. And then ultimately causing a bigger problem, and ultimately restoring it in a compromise, with a compromised solution. So you see how I restored this final crowns, right? It's 2 units splinted. 2 units splinted, sorry, let me go back. 2 units splinted with pink porcelain. A lot of bone loss. And knowing that I caused this case. So if we think about this case, why did this happen? Let's go back and think about why this happened. You look at these 2 implants, 2 completely different results. Both implants that I did immediately, but the results were completely different. Why do you think that happened? Do you remember the differences between the 2 surgeries that I did? When I did the implant surgery for the lateral incisor, 22, what did I do with that case that I didn't do with 21? Do you remember? So one, I will tell you, is one, I bone grafted when I did the immediate, for this one, for 22, we did bone graft. When I did the immediate placement for the central incisor, 21, I did not bone graft. So that's one reason, possibly, that may have contributed to the bone loss. We didn't bone graft. Another difference that I did between the 2 was the size of the implants. When I did the implant for the lateral incisor, this implant was a 3.7 diameter implant. The implant I placed in this position was a 4.7 diameter implant, a wider, larger diameter implant. So if I'm placing an implant into a socket, the larger the diameter of the implant, where are you losing dimensionally? You're going to lose dimensionally in terms of the thickness of the bone. Okay? Understand that, right? You place a wider diameter implant into the socket, you're going to take up more space because of the size of the implant. If it takes up more space, you're reducing the thickness of the bone. The thinner the implant in diameter, then the more space you have for bone. So that's why when I said this morning, I don't place anything larger than a 4.0, 4.1 diameter implant anymore, because I learned my lesson. I learned my lesson from my mistakes. So I will place a 4.1 diameter implant, and I want a bone graft. So I want a bone graft anytime I do immediate implant placements. And I know it's controversial. There are many clinicians that will tell you you don't need to bone graft, which is true. You may not need to bone graft and may still have some good results. But from what I've learned, in spite of having some bone, I still want to do more bone graft to have more confidence and more stability with the implant by having more bone. And so I know now, if I do immediate implants, especially in the anterior aesthetic zone, I'm going to bone graft those cases. I'm going to place a smaller diameter implant, a 4.1, a 4.0, or even a 3.7 diameter implant. So smaller diameter implant, more bone graft. But also you have to think about the tissue. Look at the tissue quality, right? You have thinner tissue here. So now we do a little bit more soft tissue augmentation more often than not. Connective tissue grafting or somehow building the tissue at the time of implant placement. Okay? So if we don't follow those parameters, then maybe immediate implant placement is not the treatment of choice. Then you want to start thinking about that maybe it's better to do it delayed and stage the implant surgery. Okay. But look at the results for this case. This case took me 3 years to do. Thinking that immediate implant placement was going to be the better option because we can reduce time, right? We can save time. But I didn't save time in this case. This case took me 3 years. And so in 2010, when she came back, you know, she's still a patient in our practice today, actually. So a few years after we finished this case, there was another trend in the dental implant industry, talking about BMPs, right? So it's bone morphogenic protein. And I offered to, they said, Jenny, there's this new bone material. I can grow bone vertically. You want me to do it? I'll do it for free. She said, no, no more. So she was happy. She said, leave it alone. I can take care of it. And it actually looks just like this today. So she's very good and diligent with her hygiene. The soft tissue stable. The 2-unit bridge is stable. And I've actually done a few more implants in her in the posterior. So she's still a good patient of ours. So, but I learned a tremendous amount from this case in terms of what is going to be the best options in approaching immediate implant placement. And so immediate implant placements, I don't want you to get discouraged by this because you want to learn from other people's mistakes. Learn from my mistakes. Right? Learn from what I've done wrong. And know that we can avoid these types of problems. We can avoid these types of complications. And so there's literature that supports why we want to do immediate implant placements. You know, and many of the research, many of the studies that were published earlier, they talked about the clinical success. They talked about the clinical success, but they didn't really address the aesthetic concerns. So when we read these articles, many times it was all about clinical success. And so, if you look at Peter Worley's article, this was a long time ago, 1998, he talked about the single tooth replacement in the aesthetic zone with immediate provisionalization. Talked about 100% survival. Now, there's a difference when you read these articles, when you do your studies, there's a difference between survival and success, right? What does survival mean? Survival means it's still in the patient's mouth. Okay? Success is different because there's criteria for success in regards to bone, tissue, right, stability. So there's a difference. So when you read these papers, you have to understand when it says 100% survival, it means that it's just still in the patient's mouth. Joe Kahn published an article. This was a classic article that he published in 2003. He talked about The results of this study suggest that favorable implant success rates, peri-implant tissue responses, and aesthetic outcomes can be achieved in immediately placed and provisionalized maxillary anterior single tooth implants. Again, for him, 100% survival. 100% survival, meaning it's still in the patient's mouth. It's not really telling us the final aesthetic outcomes. Maybe there's a little bit of bone loss, maybe there's some recession, right? So they're not regarding that, they're just saying it's still in the patient's mouth. And when we talk about immediate placement or provisionalization, there are guidelines and rules we want to follow. Similarly to when you do implant placement, the number one criteria is going to be primary stability, right? So primary stability, no movement. When we provisionize with immediate placements, there cannot be any micro movement. So that's why this morning I said when you cement, if you're going to cement a temporary, make sure it's a permanent cement, because you don't want any micro movement, right? That micro movement, I don't know how you can measure, but it's got to be less than 100 microns, meaning use a permanent cement to provisionalize if you're going to cement your temporaries. Okay? So you can cement it with a permanent cement. Or today, as I talked about this morning, the better option is going to be to provisionalize with a screw retain provision. That's going to be better for the patient. It's going to be better for you as the clinician, because you don't have to worry about the cement. You don't have to worry about peri-implantitis and that. So, also making sure there's no occlusion, no contacts. So it's non-functional immediate provisionalization, right? So you can immediately place your implants, you can provisionalize, but making sure it's non-functional, it's not in occlusion. There are no interferences in any movements. So when can we provisionalize? Usually when there's unrestorable crown-to-roof fractures, no infection, no alveolar bone damage. Okay, that's a big key that I also learned as well. Versus, endo, crown lengthening and so forth. But you want to make sure that, understanding that this is probably a guarded prognosis. Right? By taking a tooth, doing crown lengthening, post-core buildup, crown fabrication, those procedures can be more guarded prognosis. Predominantly involve teeth, short roots, failing endodontically treated teeth. Those can be good cases for immediate implant placements. And so when we look at immediates, you have to look at the aesthetic zone. Right? When we talk about the aesthetic zone, that means you have to look at the smile line. High smile line versus low smile line. High smile line versus low smile line. You have to look at the soft tissue biotype. Thin versus thin, thick versus thin. Looking at the gingival margin heights. Remember we talked about unpredictable gingival recession. Looking at the teeth shape, teeth size. Looking at the occlusion. So these are all factors that we want to look at when we do the aesthetic zone evaluation. Next. So you saw this patient this morning. I showed you this patient this morning. Low smile line. So you have to really do that smile line evaluation, especially with patients in the anterior aesthetic zone if you're doing a single tooth implant. Do they have a high smile line versus a low smile line? Again, we talked about with this case early clinical success, but aesthetic failure. Right? Aesthetic failure. So again, goes back to the same principles that we talked about this morning. You must begin with the end in mind. Understanding that it has to be prosthetically driven. It's a prosthetic modality with a surgical component. Same rules that we talked about this morning, right? But how do we plan our cases? Taking diagnostic models, making a diagnostic wax up. Today with digital technology, we can do that on the computer. We can send that to the laboratory. We can print it now. We can do 3D printing. But that's what's going to give us our preliminary view of what the final crown's going to look like. This is all part of that planning that we've seen this morning, right? We can duplicate that and use that as a surgical guide to do implant placement, because now we have the prosthetic result. We know the prosthetic plan, and use that prosthetic plan to guide the surgery. But also understanding that if you can't get primary stability, right? You want to have some type of a backup. You need some type of a provisional to give you a backup. And so some of the parameters are, number one, again, primary stability. When you do immediate placement, immediate implant placement, you have to have that primary stability, engaging the palatal bone. You want to look at your biotype. Having a thicker biotype with adequate keratinized tissue is going to be more favorable for your long-term clinical success. So thick biotype, more keratinized tissue, making sure that you engage the palatal bone, right, for proper placement, because that's going to give you a better option of being able to restore as a screw tank restoration. Okay? So placing it to the palatal for maximum stabilization. And then with an asterisk, it says no infection. If it's a chronic lesion, periapical lesion that's there, I still go ahead with immediate placement. But if it's an active lesion, then I'm going to stage it. Okay, we'll do that as the later approach. So criteria for placing immediate implant placement, you need to evaluate the buccal plate. Is the buccal plate intact? Right? If the buccal plate is intact, we can go ahead and we can do virtual 3D positioning and planning. So 3D positioning, you want to engage the palatal wall at least 4 millimeters for maximum primary stability. You need to follow the incisal line angle of the adjacent teeth. So you need to kind of visualize and be able to see where your prosthetics are going to wind up, and then having your implant be within the line angle of the adjacent teeth. You want to make sure that you're 1.5 millimeters away from the adjacent teeth, mesodistally. So that's spacing, right? Predicting and maximizing the space that you're in to be able to place your implant in a properly positioned place for restored maximum stability. Making sure the head of the fixture is about 3 millimeters, preferably 4 millimeters below the CEJ or free gingival margin. We say that because what if the adjacent teeth has recession? If you have recession on the adjacent teeth, then your CEJ is going to be super gingival. So understanding where your free gingival margin, where your CEJ is, and then placing the platform of your implant 3 to 4 millimeters below that level. And then you want to have, this is probably the most important, a minimum of 2 millimeters of bone thickness facial to that implant body. And that's why you want to place a smaller diameter implant, so that you can have more bone supporting the implant, because the more bone you have, that's going to support the soft tissue. Okay? So I wrote this article in 2016. It's just a simple article in terms of maximizing the aesthetics and function with immediate implant placement. Number one criteria is engage that palatal wall. We talk about engage that palatal wall, meaning we want to maximize position and stability because of where the socket is within the arch, right? When we do immediate implant placements, it's very difficult, especially in the anterior aesthetic zone. Because when you do your osteotomy drilling, where does that drill want to go in the osteotomy? That drill wants to go towards the path of least resistance. So that means as you're drilling, if you're not in the palatal wall, that drill is going to skip and it's going to want to go towards where there's no resistance. So out this way. If you place your implant in that position, where's the implant position going to wind up? More facial, more buccal. Okay? So that's why you have to really make sure that it's engaging that palatal wall, that palatal bone. Right. Looking at your CVCT, right? Understanding the dimensions of the alveolar bone. You have to understand the socket morphology of these teeth. Understanding the socket morphology, knowing that your implant position is going to engage that palatal wall. That's what's going to help determine the size of the implant that you choose. And then knowing that you're going to bone graft the space between your implant fixture and the buccal bone. And so engage that palatal wall. Right? You want to engage the palatal wall, because when you look at the socket and you do immediate implant placement, you don't want to go towards the buccal. Look at the bone on the facial. Look at how thin that bone is. It's very, very thin. Very, very thin. So we have to understand and appreciate, this is Joe Kahn's article from Jomi. He talks about sagittal root position. He talks about a class 1, class 2, 3, and 4 sagittal root position dependent upon the alveolar bone and the housing, the bone. Look at where the root positions are relative to the alveolar bone. In the class 1 sagittal root position, the apex, the roots are in a more buccal position. You have more bone on towards the palatal. Class 2 is almost in the middle. Class 3, you have a little bit more in the facial. And so understanding the classification of the sagittal root position in relation to the maxillary anterior osseous housing, you have more bone facially when you're looking at a class 1 and class 2. So there's probably almost an 85, a little bit more than 85% of roots are positioned in a class 1 or class 2 classification. In class 3 and class 4, you have less. You have maybe just over 12% of roots. But the majority of roots, and I'm sure you see this if you get a chance to look at CBCTs, look at root anatomy, look at where the position of those roots are relative to the osseous housing. It's going to be in a class 1 or class 2 relationship. And so that means we have to understand that we can place and plan our cases, knowing that we want to engage the palatal bone, because that's going to give us the best primary stability. And if the majority of roots will give you more bone palate, that's going to be what's beneficial and to give us the advantage of being able to do immediate implant placement. Okay? And so understanding, because of the studies that we've seen from previous, we know the average thickness of that buccal bone that we talked about, on average, is less than 1 millimeter thick. 0.8 millimeters thickness of buccal bone, less than 1 millimeter thick. And if the criteria is telling us you want to maintain a minimum of 2 millimeters of facial bone thickness, that's telling us that you have to probably graft that socket. We have to bone graft to be able to maintain the 2 millimeters of bone. That also means that you want to place a smaller diameter implant, a 3.7 or 4.0 diameter implant in that socket to help give you the maximum of minimum, to give you the minimum 2 millimeters of bone. I prefer to have more, 3 to 4 millimeters of bone if I can, because I know that's going to give you more better soft tissue support in the long run. And so we want to make sure when we understand, when we do implant placement, implant surgery, posteriorly you want to have at least 1 millimeters of buccal bone circumferentially, but understanding if you're going to do some type of augmentation, especially something like a ridge split, you want to have at least 1 to 1.5 millimeters of bone, both buccally and lingually. But this is a schematic showing us how to position and place your implants when you do your osteotomy. Engaging the palatal wall, right? Engage the palatal wall, but understanding if you engage the palatal wall, the angulation, if it's off by just a few degrees, it's going to change the entire trajectory of where the prosthesis is going to come out, meaning your access hole. So even though I engage the palatal wall in this scenario, look at where the access hole is coming out, the incisal ledge, right? Look at this one. This implant is not placed in the palatal wall, it's more buccal. Now I have a minimum thickness of bone in the facial. I have more room, more space here to do bone graft. That's going to give us more thickness of bone as an end result. Right? So here I have more space, here I have more space, but here I have limited space, here I have limited space. But out of all 4 scenarios, there's only one scenario where I can achieve a screw-retained prosthetic result. That's in this scenario here. Engage the palatal wall and also ensure the angle of that implant is coming out the cingulum of the tooth. Out of the cingulum of the proposed restorative design. Because just being off a few degrees changes the entire trajectory of where that access hole is going to come out. And then now you cannot use a screw-retained crown unless you use what we call that angulated screw channel. Okay? So it's only one scenario, which is the ideal perfect scenario to be able to place that implant and immediately extract the sites to do immediate implant placement. Second criteria, following the incisal line angle of the adjacent teeth. You want to make sure you're within that incisal line angle. That's going to guide you to having screw-retained restoration. That's going to guide you to having more bone facially. So making sure it's within that incisal line angle of the adjacent teeth. Making sure you're at least 1.5 millimeters away from the adjacent teeth. Because if you're too close, what's going to happen to the bone? It's going to go away. It's going to disappear. You're going to lose that bone. Okay? And then making sure the fixture, the head of the fixture, and you have to measure. You have to look and visualize of where the implant fixture is going to be when you place it in terms of depth, right? So 3 to 4 millimeters below the free gingival margin or the CEJ. That's what's going to give you the best emergence profile for your prosthetic design. You see how everything is all related to the prosthetics. It's all related to the final prosthetic design, right? Prosthetic result in terms of screw-retained, smear-retained, prosthetic result in terms of giving you best emergence profile to give you more natural contours. Okay? And then, most importantly, again, as I mentioned, 2 millimeters of bone facial. Even in posterior areas, you want to make sure that you have 2 millimeters of thickness, because that's going to support the tissue. That's going to support the tissue. And this has been debated, to graft or not to graft, right? And Tarnal will say, Dennis Tarnal will say that you don't need to graft, because if it's less than 2 millimeters, if that gap distance is 2 millimeters or less, you don't need to graft. You just need a blood clot, which is true. It's going to heal, but you're not going to have the same thickness. And so for me, I prefer to graft all my sockets. Every socket, every immediate implant placement, for me, I prefer to do bone graft. And so that's what we do. And then this will allow us to choose the correct size implant, which is why today I use a smaller diameter implant. So this is a delayed approach case, just to kind of exemplify and show you, place was the final prosthetic result. What's it going to look like? Understanding the parameters that we're looking to achieve, knowing that we have to have distance from the crest of bone to the contact to be 5 millimeters or less to help guide papilla formation, right? And so that contact point, we want to use these principles and guidelines to help shape and finalize the prosthetic design to give us the end result. So implant placement, so here's our implant placed within the alveolar bone, placed within the incisal line angle, depth control, 3 to 4 millimeters below the free gingival margin CEJ. Here's the implant. This, when we look at this, I prefer to see if we can have more scallop, but this is a flatter bone profile. The patient had lost that tooth quite a while ago. Temporary abutment, this was implant placement. This is just provisionalized on the day of implant surgery. So this is immediate provisionalization. Immediate provisionalization with a temporary abutment. We had a diagnostic wax up that we made, provisionalized on the day of surgery so that she didn't have to wear her Essex appliance. This is healing after 4 months. This is what your provisional should do. You want to use that provisional to help shape and sculpt the soft tissue, to guide the tissue in terms of the emergence. That's what we want to use the provisional for. And yes, we want to have more tissue. Some may argue and say, well, you have too much tissue. I'd rather have more tissue than less tissue. Because over time, what's going to happen is it's going to probably rebound and die back a little bit, right? But I can always take away tissue, but it's much more difficult to add more tissue. So if I have more tissue, I want to use and maximize that tissue. Custom abutment, and then in this case, today we're using, it's all CAD-CAM abutments that we're doing today, but back then it was UCLA type abutments, and then that's the final crown. And if we can learn anything, you want to have more tissue than we need. Yes, we can argue and say the gingival margins are not even. And that goes to show you, even when we do this as a delayed approach, we don't know exactly where the gingival margins are going to wind up. So would you do anything in this case with the soft tissue, with the gingival margin? Leave it alone. Let the biology heal. Let the tissues heal. Let it mature, because you can always take away later, but it's much more challenging to add. So we can look at this as an aesthetic and prosthetic success. Okay. Here's a failing central incisor. These two teeth were failing, but she only wanted to deal with this one tooth. And we explained to her, when you do a single anterior implant case, it's going to be very hard to match aesthetically. The shape, the color. And if you look at the adjacent tooth, this central incisor, look at the shading, it's going to be difficult. Look at the angle of the incisor ledge, right? But for her, she just wanted to manage this one central incisor right here. And so we told her from the beginning it's going to be a very difficult case. It's going to be better if we do both teeth together at the same time to maximize the aesthetics. But she refused, and she knew the consequences. She signed the consent, and then we went ahead and proceeded. So we went ahead, we removed the central incisor, we removed this tooth. You want to evaluate the soft tissue, right? Good keratinized tissue she had. Low smile line. She didn't really show any gingiva when she smiled. Thick phenotype, as I just mentioned. And we go ahead and proceed with atraumatic extraction. Now, for this case, there wasn't much extraction that we needed to do because of all the bone loss and having that short clinical root. So not really much attachment along that route. We go ahead, we start our osteotomy on the palatal wall. There's a socket, look at the tissue, dimensions of the tissue, pretty good. Osteotomy preparation to the palatal wall, making sure to maximize that primary stability, right? Continue with osteotomy preparation, guide pin in place, looking, verifying where the potential access to the screw hole is going to be. That looks to be coming at the cingulum, which is what we're looking to achieve to give us a screw retained restoration, right? Measuring my depth to place the implant 3 to 4 millimeters below the free gingival margin or CEJ, and then that space, right? Knowing that space is the space where I'm going to graft. So measure soft tissue depth, knowing maximizing thickness, right? To maintain stability over the buccal of that implant. This is just showing you, verifying axis of where the screw hole is going to be. And continue with implants and then bone grafting, verifying the fit. And for this case, I used her tooth for the provisional. So we're going to cut the root off. We cut the root off, and then now we're going to hollow out the root so that we can use that as a temporary cylinder, temporary crown over the temporary abutment. So we just do this manually. And I know this takes a lot of work. You want to have passive fit over that temporary abutment. And so, but you can see, we can verify that we can have a screw retained restoration using her own natural tooth as a provisional, right? Making sure we keep it out of occlusion. And then now we can build in the contours with acrylic to pick up that temporary abutment. So this is on the day of surgery, and now we're building the shape and form. We want to maximize the contours, and as Dr. Lin mentioned this morning, right, the critical, subcritical contours, that's what we're doing. We want to maximize the contours, right, to give us the best emergence soft tissue support, so that way this will lead to the final prosthetic design, right? So using her own tooth, making a screw-retained provisional, and then grafting the gap, right? The gap between the implant fixture and the buccal plate, I'm going to graft. So we use the dual zone technique. We're going to graft, and then we're going to provisionalize. So here's our provisional screw-retained, and then there's the tooth that we used from her own natural tooth to guide us to the final. Ideal provisional restoration is going to give us aesthetics, it's going to give us retrievability, it's going to give us function. But in our case with the provisional, it's really non-functional, okay? Making sure to keep it out of occlusion. Here's the occlusal view from the lingual. And then radiograph. Implant fixture placed, right? Looking at the contours is the provisional temporary abutment. And then here's the before, the after, provisional, and CBCT. But my concern is I want to have at least a 2 millimeters of thickness more at the coronal aspect. I'm not concerned at the apical portion, right? Really, at the coronal aspect, I want to have at least that 2 millimeters of thickness. That's what I'm looking to maximize. And then keeping it out of occlusion. So non-functional loading. There's the patient. And then after healing, look at the 12 tissues. This is 3 months. Right? This is how we started. So I actually have more tissue than I need, which is better. That's much better now. So uneven gingival margins, right? But still, I have more than I need, which is going to play in our favor. So now we go to final restoration. This is the challenge part. For the single tooth to match the contours, the shade. So we had to go back multiple times to get the proper contours, the proper shape. But this is the tissue. Look at the soft tissue. That's what you want to see. That's healthy, beautiful soft tissue. Maintain the volume of bone, ideally. And then now we can go ahead and start building in the restorative design. So we want to use our tools. We're going to try and match the shade as best as possible. And again, as I mentioned, right, we started from here and then just continue to go back and forth with the laboratory to match the shade as best as possible. You know, still not quite there. The gingival margin is not even yet. And then in this case, we're building in a screw mentable, screw retained cemented crown. That was the final result. So we told her that the margins are not quite even, but that eventually the central incisor number 8 is going to fail. So we were just planning for the future when she does that to treat this the same way. So here's the before, there's the final implant. We grafted the socket, nice beautiful contours, maintaining the buccal bone right from the CBCT and giving us a really nice final result. But she knows that she's going to lose this central incisor. So the margin's not quite even, but the lab did a pretty good job in terms of matching the final shading with this custom staining and so forth. So not an easy case, very difficult, especially when you're dealing with one tooth. That's the most difficult tooth. So we'll finish up with this one last case. Central incisor, patient presented with a fracture, supererupted, mobility present, right? Patient very uncomfortable. So we're gonna remove that tooth. Atraumatic extraction, really not much to remove because the tooth was already mobile. And again, I'm doing the same protocol, meaning I'm using the patient's tooth. We're gonna engage the palatal bone, right? The palatal wall. We want to have more space, more gap distance between the fixture and the buccal plate, getting great primary stability. 50, 60 newtons of support, right? We saw that this wasn't fully engaged because of the adjacent levels of where the bone was, because we countersunk the implant. So we're using a temporary abutment, and then the same protocol. We're going to cut the root. We're going to hollow out the patient's tooth, the patient's crown. And then this is just a temporary abutment that we prepared. And again, same protocol, keeping it out of occlusion, dual zone technique, grafting the socket. There's our implant fixture, let that heal for a few months. Again, I'm always grafting because otherwise you're gonna get collapsed. We're gonna get collapse of that buccal plate if you don't graft. 1 week post-op, nice, healed, stable, keep it out of occlusion. And then 3 months final post-op restoration. So that's the final restoration. The laboratory did a pretty nice job in terms of shape and contours. Patient was 84 years old, very happy with the result. Final restoration, and really not a concern for him regarding that black triangle. So here's the final prosthetics. Here's the before, using his tooth as a temporary, and then the final zirconia restoration. Here's the radiograph. Single tooth, immediate implant placement, immediately provisionalized, and then restored as a screw retained. CBCT, look at the buccal bone. Right? That's what you want to see. That's what you want to maintain. That's what you want to maintain. So those are the things that we can accomplish if we follow the guidelines, making sure we adhere to the principles of maximizing bone, maximizing stability to give us not just the best biological and functional results, but they're also the best aesthetic results as well. Okay, so in summary, diagnosis and treatment plan accordingly, right? You want to make sure that you can temporize at the time of implant placement, make sure you have great primary stability, but make sure you follow the protocols. Make sure you follow the guidelines. Plan, scan, and plan some more. You heard that over and over this morning. It's all about the planning. It's all about the planning. But we know that if you do immediate, it can work. And the success rates are very similar, very compatible to if you were to approach this as a delay, if you follow the rules, if you follow the protocols. You saw this video literally, I'm not going to play it again, but thank you. Just on time.